Thank you for kind introduction. I'm focused on the lung metastasis. The liver cancer can go anywhere in the body. Intrahepatic metastasis is the most frequent site, but it can go to the lung. It may be the second most frequent site of metastasis. I'm focused on the metaclonus pulmonary metastasis. It happens. We can perform some local regional treatment. It includes resection, radiotherapy, ablation, and sometimes TACE and other modalities. Today I'll focus on 3 treatment modalities. The first one is resection. You can resect by open method or videoscope assisted. We call that BATCH. The indication for pulmonary metastasis resection includes that it's feasible for complete resection. If incomplete resection, it is not it leads to incomplete resection. It's better not to do. And sufficient pulmonary function after lung resection and up to 3 isolated regions, regardless of bilaterality. Left and right region, it's okay. But the number is a limitation, but it's not absolute. Up to 5 is okay sometimes. And isolated recurrent lung region after first resection. Recently, last 5 years, there are several reports from Japan and Korea. Now I'm talking on the 4 reports with a large-scale volume. The first report from Japan is Metastatic Lung Tumor Study Group of Japan, and 61 patients were enrolled. In their study, after resection of lung region, 5-year survival rate was 32%. And from initiation of primary surgery, their survival rate at 5 years is around 50%. In this study, they found that the tumor number greater than 3 is a significant risk factor, and then others are not significant. The second study is from Korea, Seoul National University. There's 41 cases, including 12 cases of liver transplantation. This is disease-free survival curve, and 5-year disease-free survival rate is around 25%, and overall patient survival exceeds 50%, around 60%, very favorable. And in this study, the significant risk factors are lung region multiple, 2 or more, and the lymph node metastasis and presence of extrapulmonary and extrahepatic metastasis. And the third study from Korea, Samsung Medical Center, disease-free survival rate at 5 years around 30%, and the 5-year overall survival rate after resection was 37%. This report also shows favorable outcome after resection. And in this study, the significant risk factors, the lung metastasis as the first recurrent site. And similarly, for risk factors favoring survival after resection is that tumor number 1 or 2, no lymph node metastasis, and isolated lung metastasis without other site of recurrence, and first metastasis at the lung. If this condition is met, favorable outcome will be achieved. Now I move to the lung metastasis after liver transplantation. Actually, after liver transplantation, any recurrence will be distant metastasis. Intrahepatic metastasis will be distant as well as lung metastasis. In our series, in our 600 patients, we identified 47 patients suspected of lung metastasis. Of them, 23 patients underwent surgery. We divided the patients into 2 groups. When the region was small or multiple, but it appears resectable, they underwent the surgery, and pathologically 23 was identified as metastatic. And other patients, multiple regions with extrapulmonary metastasis. They did not underwent surgery, and this is non-resection group and resection group. We compared the patient profiles, demographics, type of surgery, tumor extent. It's nearly the same, but the non-resection group had extrapulmonary metastasis. And first of all, we look at the sequence of lung metastasectomy cases. Number 23. In 18 patients, they were first metastasis at the lung, and the other 5 patients had a prior recurrence at the liver and the diaphragm and others. After resection, many of them showed recurrence, and 9 patients underwent repeat resection, and 2 patients underwent third resection. In our series, only 4 patients did not show further recurrence, and other patients have recurrence, oral cavity, liver, lung, and others, brain. This is the usual course after recurrence in liver transplant patients. Look at the first lung metastasectomy profiles, unilateral most common, and video-assisted surgery was more prevalent. And the bilateral resection can be done, and concurrent resection or sequential left to right resection. In this surgery, in these 23 patients, 41 nodules found, and most single lymph node metastasis found in 2 patients. And the second metastasectomy was performed after 9 months, and usually single region with unilateral resection, and third resection was performed 3 months and 13 months. And there's no complication after lung metastasectomy. We do not know, hepatocellular surgeons do not know where, because this type of surgery is done by the thoracic surgeons. And let's look at the treatment in non-surgery patients. Systemic chemotherapy was done, and local regional treatment, including TACE and radiotherapy, was performed. And a small proportion of patients did not receive any treatment because of poor condition and rapidly spreading multiple tumors. And this is a resection group. This lung metastasis free means that this timing of occurrence of lung metastasis. And after resection, after 3 years, 30% of patients survived. This is a non-resection group, the timing of lung metastasis. And it's overlapped. The timing of lung metastasis in non-resection group and the resection group nearly the same, except for the portion. But after treatment, non-resection group and resection group showed a better outcome, especially for these 30% of patients showed a prolonged outcome. Actually, this is surgery intended to find out these patients. And overall patient survival after lung metastasis and overall survival, including the surgery, the survival from liver transplantation to patient death, it looks like this. In non-resection patients group, most of patients died within 5 years, but although recurrence happened, in resection group showed about 40% of patients survived for a long period. We tried to find out the risk factors, expense pathology, recurrence timing, PET uptake of tumor markers, and interval to lung metastasectomy type of surgery, tumor nodule, number, size, sorafenib used, but we failed to find any significant risk factors. But and you look at the surveillance, effect of surveillance. For after liver transplantation or resection, chest X-ray is often performed, but its predictability is very low, only 43%. This means that most of lung metastasis can be missed. CT scan showed very accurate predictability, high predictability, and its sensitivity and accuracy is around more than 85%. And many of the extrahepatic metastasis was diagnosed after lysis of tumor markers, and they lead to imaging study. In half of our series, patients was first recognized with the lysis of tumor markers AFP and TPK2. And the PET scan show predictability around 2/3 of patients. And for liver transplant patients, the risk factors can be summarized as this. It's indication for resection, tumor number 1 or 2, no metastasis and isolated metastasis post recurrence. This indication the same as for after liver resection. Let's move to another treatment modalities, external beam radiation therapy. The tumor is located here, and the CT simulation was performed to design the beam radiation therapy. This is an example. The tumor is located here, and the radiation therapy was performed. As time goes, tumor regressed. In this Chinese series, there's 13 patients. Let's look at response. Tumor progression was observed in only one patient, one of the 13 patients, and complete response was observed in 2 patients. Other patients showed partial response or stationary disease. And most of the patients showed improvement of symptoms. And the side effect of external beam radiation therapy is really negligible, and only leukopenia and the fever and others is acceptably tolerable. And the progression-free survival curve at 2 years is around 20%. And the overall survival curve showed that very favorable outcome. But when you look at this data, the patient must be very highly selected. I summarized the external beam radiation therapy. The dosage is around 50 to 60 gray, and it showed good, acceptable palliative effect, and it showed reasonably favorable safety. But this is the only study I can read. I can search in the PubMed central review. So further large-scale studies should be done to validate the effect of external beam radiation therapy. Another local regional treatment is radiofrequency ablation. The needle can penetrate into the lung directly like liver. This is a Japanese multi-center study from 6 institutions, 32 patients enrolled. Of them, half of them, 16 patients survived, and another 60 patients died. Let's look at the patient profile. The number of lung metastases is usually 1 or 2 and up to 6. And they survived after RFA from 1 year to 7 years. And some of them recurred at the lung or bone, others, but with the adjuvant therapy, they survived now. Look at the deceased patients. The number is most 1 or 2 or multiple. And let's look at the cause of death, intrahepatic recurrence, most common cause of death, bone metastasis and lung metastasis. They survived from 3 months to 40 months. And this is the survival curve at RFA. At 3 years, around half of patients survived in this series. Let's look at the complication. Because the needle penetrates into the lung, there's no mortality, pressure-related mortality, but complication occurred in 60%. Most of the complications are pneumothorax. In 25% patients required a chest tube. And there's 1 case of bleeding. In this patient underwent radiofrequency ablation And after 1 week, the patient showed hemoptysis due to pseudoaneurysm formation and arterial embolization was performed to control the bleeding. And others showed the pneumothorax mild and does not requiring a chest tube insertion. As a summary, the RFA to the lung seems to be effective local control measurement with acceptable safety. But it is also the only large volume study ever. As someone in my talk, local control of lung metastasis can be achieved through resection or radiotherapy or RFA. If local control is done safely, and it often provides prolongation of patient survival. And the best indication is the post-isolated lung metastasis. And it is necessary to set up logistics, how to select the patient, how to select the treatment modality for lung metastasis. Thank you for your attention.